Welcome to the Jason Podcast. I'm Josie Briggs, Editor-in-Chief of the Journal of the American Society of Nephrology. Each month in this podcast, we talk about a paper in the current issue with the hope this discussion will prompt you, our listeners, to go to our website or turn to the latest issue that is now in your mailbox. I'm delighted to have joining me today Andrew Rule. He's a member of our team of associate editors, and he and I have been working together for the last 5.5 years. He's a professor of medicine at Mayo Clinic School of Medicine. Andrew, thank you for joining me for this conversation.
Glad to be here. Thanks for the invitation.
So Andrew's the corresponding author of the paper we're going to talk about today. And I want to give just a slight aside here. Whenever a member of our team submits a manuscript to Jason, we use a very tough guest editor process to ensure we get a thoroughly independent and tough review of the work. We recruit a guest editor who's a recognized authority on the topic, and they select the reviewers, compile the review suggestions, and basically call the shots. We do that to ensure independence of our processes. Jason is a highly competitive journal. We think our readers benefit from a tough process, and we do our best to put the most impactful work in front of them. So we reject many more papers than we accept. And guest editors recommend reject at times for work submitted by our own editors. We live with that. But this paper was very enthusiastically reviewed by our outside editor and the peer reviewers, and we are delighted to be publishing. Congratulations, Andrew. So the paper we're talking about today is entitled An Improved Method for Estimating Nephron Number and the Association of the Resulting Nephron Number Estimates with Chronic Kidney Disease Outcomes. The first author is Alexander Denik, and you, Andrew, are the corresponding author. So to begin, explain to our listeners why you took this on. Why did you want to develop an improved method for estimating nephron number, and why is the question important after all?
So there has long been interest in the extent to which nephron number determines GFR and ultimately predicts development of CKD, both in settings of chronic disease and in disease that begins early during development and with aging. So nephron number reflects two factors: the nephron number, that is the number of nephrons you are born with at birth, and nephron loss due to aging and disease. There has been concern that certain individuals, particularly those with low birth weight and premature birth, start out with fewer nephrons and are thus more susceptible to developing CKD later in life. We have published a previous estimate of nephron number in living kidney donors, actually here at Jason in 2017, but decided there were a number of reasons it could be done better, and we wanted to explore the prognostic importance of nephron number for developing clinically recognized CKD.
So let's get into the specifics of your paper. An improved method for estimating nephron number. That's the first part, and then the data supporting your conclusion that nephron number can predict future risk. Explain to listeners how you undertook to improve the estimate of total nephron number. So
we used data from the Aging Kidney Anatomy study, which included 3,020 living kidney donors and 1,354 patients who underwent a radical nephrectomy for a kidney tumor. These patient populations were specifically chosen as they're relatively normal persons where you have access to both a kidney biopsy at the time the kidney is removed and a CT or MRI study of the kidneys just prior to the nephrectomy. You need both a biopsy and an imaging study to determine nephron number. Essentially, you multiply the density of the glomeruli on the kidney biopsy by the volume of cortex on the imaging study. But you need to have an accurate estimate of glomerular density in the cortex on the biopsy and an accurate estimate of kidney cortical volume on the imaging study for this method to work. Our paper made several methodological improvements to improve the estimate of total nephron number per kidney. First, we now account for the dislocated or missing glomerular tufts that are lost during the tissue processing. This actually happens to about 16% of the glomeruli in the needle core biopsies of living kidney donors. Second, we also separately studied 30 autopsy kidneys to more accurately determine the amount of tissue shrinkage that occurs with formalin fixation and paraffin embedding of kidney biopsy tissue. Third, we better accounted for the depth of the kidney biopsy by adjusting the glomerular density estimates to be higher when the kidney capsule is not present on the biopsy. This is needed because the glomerular density is higher near the capsule of the kidney, as glomeruli are packed closer together when they're more superficial, but are dispersed further apart when deeper by the descending loops of more superficial glomeruli. Fourth, we now account for the imaging slice thickness of the cortex, as thicker imaging slices will overestimate the volume of the cortex. Altogether, accounting for these approaches, we had a 27% higher estimate of nephron number in kidney donors compared to our prior study.
So what's the new final number?
In a healthy man, in a healthy man in their 20s or 30s, it is about 1.4 million per kidney, and in a healthy woman in their 20s to 30s, it is about 1.25 million per kidney. However, these counts decrease with older age. Shorter individuals also have fewer nephrons than taller individuals. These counts also decrease in persons with hypertension, who have a family history of end-stage kidney disease, who have lower GFR, or who have abnormal levels of urine protein.
Yeah, it's actually a big change in a definitive number. At first, our reviewers wanted more detail because they were surprised at an estimate that was 25% higher than previous estimates. But you worked through with substantial detail all their concerns, and they really felt that this was an important new estimate. I found it interesting. Years ago, I measured single nephron GFR, and of course, if you want to do any calculations with single nephron GFR, well, of course, that was measured in rats and mice, but you also need an estimate of total number. So it does. It's a useful number when you move from single biopsy determinations to estimates of the whole function. However, the second part of your paper may seem to many people even more important, and that is the question, does nephron number in these young, well, healthy people actually associate with CKD outcomes? So tell our listeners how you approached that and what you learned.
So we tend to think about CKD as proteinuria or a low GFR, but in theory, chronic kidney disease occurs when your number of functioning nephrons is inadequate for your metabolic needs. And so in our study, however, we wanted to know, how does your low nephron number predict the onset of the clinical evidence of CKD by either a low GFR or by a decline in your GFR over time? And so we looked at this in both the living kidney donors and in the kidney tumor patients, and we found that in the living kidney donors, you were more likely to have a reduced GFR both in that first year after donation as well as a full decade after donation. And we found that likewise in the patients who had a nephrectomy for a kidney tumor, those with low nephron number were more likely to have a progressive decline in eGFR by 40% or to develop kidney failure. And importantly, this association between low nephron number and subsequent onset of CKD was not simply due to differences in kidney function or CKD risk factors or other kidney biopsy findings between persons with low nephron number and persons with high nephron number. Thus, this means that nephron number tells us something unique about the risk of developing CKD that we cannot get from other clinical or biopsy data.
Yeah, this is really important. So to apply this in future studies, you need both a biopsy and an imaging study. What are the kinds of questions where this really definitive approach might be used?
So this is an approach you can use in living humans, which is, some of the other approaches don't have that ability. They have to be used in deceased autopsy cases. But these methods can be used in any patient where there is both a kidney biopsy available and either a CT or MRI kidney imaging available around the same time. It's important to note that the precision of the method is limited, and this is because your estimates of glomerular density on a needle core biopsy are somewhat imprecise. However, you can still use this approach to reasonably identify patients who have very low nephron number counts. And I think further research is needed to determine whether this would be useful clinically to guide care. Now, I think as a research tool, we can learn a lot about human physiology. We can divide a person's GFR by their nephron number, as you mentioned, to estimate single nephron GFR. And this allows us to study the effects of various medications and interventions on single nephron and on nephron number, the two components of GFR. This is important as an intervention that lowers single nephron GFR may be beneficial by reducing stress on the glomerulus, whereas an intervention that lowers nephron number is inherently harmful. By assessing for a reduction in GFR alone with an intervention, this will not distinguish whether the reduction in GFR is due to a decline in single nephron GFR or loss of nephron. So being able to distinguish those two is important. And there's also unresolved issues with low nephron number and birth weight in particular that this approach could potentially address in the future.
Okay, congratulations again on a really important contribution. As we wrap up, as I mentioned, you and I have been working together now on Jason for almost 6 years. I've really valued your critical insights as we work through the peer review of work submitted to us. We're getting near to our end of our term as editors of the journal. Jason brings in a new team every 6 years. So do you have any thoughts on our work together and specifically on the peer review process? How do you think we are doing?
Well, Dr. Wiggins, first I just want to thank you for this opportunity to serve as an associate editor for Jason for now almost 6 years. It's been both an honor and an incredible learning experience for me. I think regarding the peer review process, I think it's imperfect, but still of very high value as we want to publish the highest quality papers, and I think we have done so, and hopefully we'll continue to do so. Both papers I've overseen as editor, as well as my own papers, have improved substantially with the peer review process. I think most academic nephrologists will review on their own time because they love the science and they desire to see improvement in the care of our patients. I also think the editorial fellows we have had have been very helpful, not only to add new insights into the reviews, but also to provide us an opportunity to encourage and support the next generation of kidney scientists in our field. So once again, thank you for this opportunity.
Well, it has been fun working with our early career scientists as editorial fellows. I think all of us agree we're learning a lot from them. Sometimes they're closer to the methods. Sometimes they have a range of informatics or other skills that the more senior members of the team don't have. And so I'm proud of the impact that's having. And thank you to our listeners for joining us for this podcast. Take a look at this issue. I think you'll find Dr. Rule's paper to be an impressive contribution and probably find other things there, whatever your specific interests in kidney disease are. So thank you, Andrew, and talk again soon.
Thank you.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.